All right, we're going to go ahead and get started here. Thank you all for joining this webinar session hosted by WHO and UNICEF on costing and budgeting for WASH and healthcare facilities. My name is Lindsay Denny, and I'm a WASH program specialist at UNICEF based out of New York at headquarters, and excited to bring to you this third session in our technical webinar series. If you haven't seen the previous sessions, we did a session on WASH Fit, and then we did a following session on healthcare waste management. And today we're excited to bring you a session on costing and budgeting for WASH and healthcare facilities. And the key question we'll be discussing today is how do we leverage the data on costs to make the case to decision makers to finance WASH and healthcare facilities? So you'll be hearing from various experts in this space around how we talk about costs and budgets, around how we collect this information, around what is currently existing and how we can put together a case. And then you'll be hearing from experiences from the countries. We have Nepal and we have Tajikistan with us today, and they'll be talking about their experiences leveraging this data, collecting it, and then utilizing it for various purposes to encourage greater financing for WASH and healthcare facilities. So with that, we'll go ahead and get started. I'm very pleased to introduce Dr. Darcy Anderson, who is a postdoc fellow at the University of North Carolina at Chapel Hill. She has done extensive work on putting together tools for budgeting WASH and healthcare facilities. And so no one better to start us off here than Darcy. Please go ahead and give us your overview of costing and budgeting.
Great, thanks, Lindsay. Yeah, so as Lindsay mentioned, I'm here to provide an overview of some key terms, to do a review of some of the tools and data that are available in the sector. Next slide, please. So I'll start with reviewing some key terms. You'll hear these a lot during today's webinar. When we say costing, we're really talking about a process to determine how much money is required to deliver WASH services. One of the ways that we may do this is to identify the activities and inputs that are required to deliver a service, and then identify their associated cost. The economics can get more complicated, but at its most basic, we're thinking about an equation where the total cost equals the quantity of goods that are used to provide a WASH service, and then multiplied by the unit cost of those goods. This tends to be a more technical process where we're answering the question, how much money is needed to achieve and sustain WASH services? If we compare this to budgeting, then we're really looking to determine how much money will be allocated over a given time frame. Notice that the amount of money that's allocated may or may not be the same as the amount of money that's required to deliver a WASH service. In budgeting, we're identifying the funders and funding sources that will be used to pay, and we're creating a plan. And this process tends to be more political compared to costing, which tends to be more technical. Instead, we're asking who will pay, how much, for what, and when. Next slide. So why do we do budgeting and costing? Well, one, we're looking to understand the true costs of service provision. We know that certain expenses tend to be overlooked, and these tend to be the things that we can't see or things that occur farther into the future. So things like maintenance that may happen 5 to 10, 20 years after installation, training, supervision, other things that are difficult to see. Budgeting and costing can help plan programs. We can evaluate and compare the different interventions through things like cost effectiveness studies. And we can ensure that there's sufficient funding to reach targets either laid out in policies or to do program activities that are planned if we know how much those things are going to cost. And then finally, budgeting and costing help inform sustainable investments. They help stakeholders reach agreements about what funds are necessary, and they help to avoid investments where there may be infrastructure that's constructed, but then the long-term costs of that operations and maintenance need to be funded as well. So we like to avoid situations where we've paid to install infrastructure that we then cannot afford to operate and maintain, and that infrastructure falls into disrepair, and that investment is largely wasted. So I'll talk through a few scenarios, and you'll see some of these in the case studies today. But we can do costing and budgeting in different orders. So doing costing first, you can imagine a scenario where a funder may commission a costing study to estimate the costs of achieving a basic wash service. Consultants are hired to do that costing study using some sort of representative sample of healthcare facilities. And then funders use those cost data to develop budgets. Some of the advantages of this approach, it tends to be more accurate in order to plan for true costs because there's that upfront time spent to gather some data. It can help avoid upfront investments where the operations and maintenance is unaffordable down the line. And there tends to be fewer surprises about what you're buying, how much it's going to cost. Some of the disadvantages of this approach, it can be quite slow. Primary data collection is expensive, and there's limited secondary data to do costing studies without being present in the field and doing that primary data collection, which tends to be slow and somewhat expensive. So under a second scenario, we can imagine that we would do budgeting first and costing second. This scenario may be somewhat more realistic, where funders have allocated a fixed amount for Washington healthcare facilities, and then implementers need to figure out what they can afford within that budget. Maybe doing some more informal calculations to understand, okay, how much money is there? What can I buy? What are my options? And picking the options that fit within that budget. And then implementers develop a plan for those options. The advantages of this, typically somewhat faster, that the costing may be slightly more informal. As I said, it tends to be a bit more realistic in terms of how the budgeting process usually plays out. Some of the disadvantages of this approach, there can be surprises where if a full costing study wasn't done, things that maybe weren't anticipated, unexpected repairs or other supplies that maybe just weren't thought of in the budget can surprise you. And sometimes you're looking at more trade-offs where there may not be enough budget to implement all of the activities or purchase all of the supplies that are needed. So under a third scenario, this is doing both budgeting and costing together. And we'll see some case studies today about what this might look like. This kind of combines the best of both worlds, where there may be some budget for Washington healthcare facilities that already exist. And then costing studies are done by stakeholders to demonstrate gaps between the available budget versus the needed budget. And then champions use that data to advocate for increased budgets to overcome that budget shortfall. So I'll close today with talking about the data inputs that are needed for costing and budgeting and some of the tools that you might use to collect them. So when I teach budgeting and costing, I teach people to think about life cycle costs. And what I mean by life cycle costs is there's 3 phases to a wash service or installing a particular piece of infrastructure. The first phase is installation. This is the thing that most people tend to budget for. It's the most visible cost that occurs first. That's the cost of infrastructure, consumable supplies like soap or detergents that may be provided alongside the infrastructure, and then software, things like training, setup, testing, if there's any sort of licensing or site preparation that needs to be done before construction. These are all installation costs. Once a wash service is installed, you move to the operations and maintenance phase. During this phase, the specific line items that may appear in a budget include things like infrastructure repairs, trainings, the salary of personnel that are required to operate and maintain the infrastructure, ongoing consumable supplies like fuel for an incinerator or soap, and then the costs of supervision and support. Finally, as infrastructure reaches the end of its lifespan or a service comes to an end, there's a phase of decommissioning and disposal. And this phase is the least often included in budgets, but it can be quite expensive. So when infrastructure reaches the end of its lifespan, it needs to be removed. There may be additional costs to prepare the site to, for example, clear out the old infrastructure, make the site safe again, dispose of it, and then reinstall new infrastructure or rehabilitate old infrastructure in some way so that it can restart its life cycle again. So if you, after this session, you're doing costing or budgeting, I encourage you to think about these 3 categories and the costs that fall within them. So some tools that are available if you plan to do costing and budgeting, I'll highlight some here. This list isn't exhaustive, and I'll provide an overview. As you'll see, there's some QR codes on the screen here. When the recording becomes available, you can follow those for additional information. UNC has a costing toolkit available, and there's a variety of training materials to support that, as well as some policy briefs that can be used to communicate with stakeholders. We also have a case study available, which my colleague Lakshman will present today, and you can contact me for the preprint of that if you would like to read in additional detail. But some key features of these tools, they're designed for lay users or practitioners. So for a non-technical audience out there with no prior costing experience, these are designed for you. They're designed for data collection at the facility level and for primary healthcare or smaller clinics. Some of the other tools that are available, there's been information from WaterAid that's been released. It's not yet available, but if there are colleagues from WaterAid that are on this call that have more up-to-date information than me, please do provide that in the chat. I'm eager to see those. But WaterAid has been doing participatory costing information or costing assessments in Timor-Leste and some other countries. So we're looking forward to seeing those reports. And costing tools from non-healthcare facility settings can be useful. I've highlighted several here on the screen, but there certainly are others, both for household and school settings. And my last slide here is on secondary data and costing studies. Unfortunately, there is not a lot of good secondary data to inform costing and budgeting, not unlike the JMP, where we have kind of robust monitoring data across many different countries. That doesn't exist for costing. So if you're someone who has costing data, I encourage you to make that publicly available so that we can help advance the sector in this way. I'll highlight 2 studies you see there at the top. There's a study that was done in 46 UN designated least developed countries. That's so far the largest costing study to date. And then there's a systematic review that looks at cost studies, about 60 cost studies across different countries. And then there's some additional geographic specific studies there. I encourage you to take a look at the recording and review those references later. Great. That's it from me. Thanks, Lindsay.
Thank you so much, Darcy. I think that was just a phenomenal overview. As someone who is not a financial expert, I think I throw around the terms of costing and budgeting and financing pretty liberally. And so it's really helpful to hear the background on that and what tools are available. So thank you so much for that presentation. If you have questions or comments for Darcy, please put them in the chat. We'll have a pause between presentations for some questions on this more technical side of things before we hear from the case studies. And also feel free to introduce yourself. I should have said that earlier. Would love to know who all of you are who are joining us today. So please feel free and share that. I believe Nadia shared the slides for this presentation already. So you can actually go in and if you want to follow along, and you'll also be able to click on the links that Darcy shared. So thank you very much, Dr. Anderson, much appreciated. And now I want to pass over to Claire Chase, who is a senior economist at the World Bank. Claire is probably the foremost expert on financing when it comes to Washington healthcare facilities. Claire, I don't know if you meant to get that title, but you are certainly become that individual. So excited to hear from you on what you understand utilizing the cost of data to finance Washington healthcare facilities. Over to you.
Thank you so much, Lindsay. And no, I didn't know that. But we're certainly, really happy that this work is moving forward, as it's such a critical area. So thank you for the invitation. Really happy to be here as part of this series. I'm just going to talk briefly today. You can move to the next slide. I'm going to talk briefly today before we get into the case studies about how the World Bank is using the costing data evidence that we have already, and how we're working with partners to extend those analyses in order to make the case for funding and for financing. So Darcy talked a bit about the differences between budgeting and costing, and I also think about differences between funding and financing. So that's another terminology that we all need to sort of come together on. And then I'll talk briefly about work that the World Bank has supported in Madagascar, building on the review that WHO UNICEF led for the 46 LDCs. And then finally, I don't have any answers today, but it's more about just starting this dialogue on deciding who pays and bringing that into the conversation. So you can move to the next slide. So I hope that all of you are familiar with these results that were led by WHO and UNICEF, the work that estimates the cost, the price tag of achieving universal access to wash and healthcare facilities for 46 least developed countries. And I really, I think that this has completely transformed the dialogue and the conversation on investing in wash and healthcare facilities. We talked for a long time about the need to generate evidence on the cost, and I think it has really moved us forward and motivated a lot of discussions. And I mean, I certainly have been able to use these and various conversations with our leadership in the World Bank, with governments. So I think they've really had a lot of traction. And I think, next slide, those estimates were also very useful for us to begin to understand some of the differences across populations in terms of where the investment needs are. So if we're supporting the government to prepare a water and sanitation program in a country, we also need this evidence to be able to show that the investments really need to take place, at least for wash and healthcare facilities, in the rural areas for most countries, at least in this study. And then also, where do those investments need to take place? Oftentimes there's emphasis on the hospital level, the more tertiary care level, because it's the most visible. It probably requires the most sophisticated wash infrastructure. But as we see from the global study that was done here, most of the needs are in non-hospitals and more primary care settings. So that helps to motivate some of that discussion as well. Next slide. And then I think that it was, very intentional that this work presents the cost estimates in terms of the cost per capita. And that allows us, as you see from this slide, to compare across different other expenditures or spending and how this relates to those other expenditures. So I think the most important one here is that if we see the annual investment needs per capita for wash and healthcare facilities in LDCs, the top one here, between 54 and 79 cents per capita, compare that to recurrent spending by these governments on health, and you see that it's really just a small fraction of what's being spent. And that helps us to, take this discussion further. So I think this has been, as I said, very valuable information and data for us to be able to have these conversations, but it can only get us so far. And I think that's some of the challenges that we have faced. Now that we have this evidence, we have countries asking us, well, how much does it cost in this country to achieve universal access? So we need to take this evidence forward to do not just for the least developed countries, but many other countries that have very low access, that are not in that category, that also we need to develop the evidence for those countries. Obviously, at the country level, we need to understand what are the costs to achieve universal access. And then getting back to what Darcy was talking about on the budgeting versus costing, once we have those financing gaps, once we understand what the financing gap is in a country, it comes down to the project preparation and how much needs to be allocated for that particular project and for the budgeting of the services. So what we've been working on over the past couple of years since this has come out is working with partners to advance on some of those additional analyses so that we can get as much leverage as possible out of this. So let me just give this example. of work that was done in Madagascar, building on the Lancet study. This was a collaboration between our health and water practices, where there was a request from the vice president of the region to understand what are the costs to enhancing the primary healthcare services in countries in the region. In Madagascar, I'm just giving the example. This was also done in other countries. So they are looking specifically at water supply and electricity. So this is not a full wash in healthcare facilities cost assessment, but just looking at the water supply as one indication. So what they did was firstly to gather the gaps in access, coverage of water supply and electricity and healthcare facilities across the country. They determined what would be required based on those levels of coverage to achieve the basic levels of access and then electricity access in the healthcare facility for each type of healthcare facility. And then for the unit costs, they used data from the project implementation. So projects that had been under implementation, they were able to collect the costs from those projects. They also looked at some donor-funded projects and the costs of those, and then used the Lancet figures to sort of calibrate what they were finding from these other sources. And then they developed different scenarios for scaling up. And the top level finding there was that a total of 98.5 million was needed to achieve universal access. And then they looked at what was already being spent through projects that were in the pipeline or were already ongoing, and identified the financing gap of 85 million. So now when the World Bank or another multilateral development or donors come into that setting, we have a very concrete estimate to be able to inform the financing. So as I mentioned, we've been working with partners to expand this costing work because we do see that there's a lot of demand and a lot of opportunities to generate this evidence. What we're finding, so what we've been working on lately, so these are just some examples of countries that we're aware of. I think these are a mix of UNICEF and World Bank. But what we've been working on internally at the World Bank, building on the Lancet estimates, is to expand those globally and eventually get to the regional or country level. Actually, the challenge that we're having, I mean, we have the data, the cost estimates from the study, but a lot of the challenge that we're having is, as you know, in many countries, we don't have good estimates of coverage. So we're having to make a lot of assumptions, and that makes it very difficult to have much confidence in the total costs that are needed because we don't know what the coverage is. So that's, you know, another data challenge that we're facing. So finally, my last slide, just getting a bit into this discussion of who pays. And it's not, we all know it's not that there's funds sitting around. So even when we have these cost estimates, it's not that we can go to the country and you know, immediately have access to resources. So the one of the recent Washington Healthcare Facilities reports from WHO and UNICEF identified some of these statistics from GLASS, just 11% of countries having sufficient resources to reach the national targets. That was back in 2019. And then just a quarter of national budgets having line items for Washington Healthcare Facilities. So clearly, we need to go out and look for these resources. And when thinking about the mix of funding sources, right? So it's not all going to come from the health sector. It's not all going to come from the water sector. There needs to be different contributions on the different areas of the different stages of those investments, right? For the provision versus the actual operations and maintenance, or what's happening inside the facility. So identifying who can pay for those recurrent costs, who can pay for the capital costs, the types of service, that's also going to be potentially different, provide different funders, and also the service chain. So if we think about sanitation, if it's a networked system, who's paying for the network up to the facility, the actual sanitation toilet within the facility, or if we're talking about fecal sludge management, right? There's a various different funders, providers, private sector that has to come in to the this picture. So I think that, one, would be good for discussion is sort of thinking about how do we come up with a guiding framework for some scenarios of who is paying and what are the potential sources of those funds. I think that's the next big discussion, and I'd be very eager to hear if anybody on the call has experience with that. So thank you so much, Lindsay, and everyone.
Thank you so much, Claire. And really fantastic. I think that last question is one that I feel like often is unspoken in many of the meetings we've been to over the years, whether it's in a country or a global meeting, something people sort of want to skirt around. And what I think is exciting is that we are at the maturity of this conversation where we can actually start pushing that forward. And I think we're ready to be more explicit around this and bringing together the WASH, the health, the financing to the table to say, who's really responsible for what, and that's going to vary by situation, I'm sure. But does health pay for operations and maintenance? For sure. What are the things that are expected? So really phenomenal, and I think I need to be better with my parlance here of costing, budgeting, financing, and funding. So thank you for putting that to us. Something I think we could all improve upon. And thank you for that explanation. I want to pause here. I haven't been following along in the chat, but I do want to see if there's any questions coming in. Maggie, has anything come up that we should pause and look over for Claire or Darcy?
Wait, what is it?
Hi, Maggie.
No, but I actually have a question. I was typing it, but I don't know if you want me just to
Please
ask
go
it.
ahead.
Okay, so thanks, Claire and Darcy. This is actually for both of you. I'm just wondering if you could speak to like how the costing and the budgeting work has translated into increases in budgets or increase in investments. And we're certain, because we know the health sector is quite big, right, and diverse, we're certain entities within, whether Madagascar or some of those other countries you've listed, Claire, more kind of interested in the work than others. So yeah, that's for both of you. And really great point about, coming up with a really clear framework about the different scenarios in terms of the types of services, who pays. It's quite complex, but I think it could, give some kind of guidance, right, towards that next step, which is really about, getting these services financed. Over to both of you.
So, maybe I can just start. I think from our side at this point, it's more about positioning the evidence where it needs to be. So as I mentioned, we've used the cost estimates in conversations that our Vice President for the East and Southern Africa region has had with the ministers of finance from those countries. So, even just raising the topic in those conversations, I think is more about positioning, and now that has to translate into the actual program design. And I don't want to get into the details of what we're seeing now at the World Bank with what we're calling the Global Challenge Program, but those do have, both from the Health Global Challenge Program and the Water Global Challenge Program, an emphasis on scaling up access to WASH and healthcare facilities. So right now it's more at a regional level. So there's sort of umbrella programs that are being prepared, and then those will trickle down to the actual country programs. So we'll be able to give more, I think, indication of impact of these numbers probably in 6 months time or so, but definitely we'll share what we are able to do with that.
And to add to what Claire has said, as an academic, I tend to do more data collection and less advocacy. But we are lucky to have Lakshman on the call today, who's got a case study where the Terrorism team in Nepal actually used some of the costing tools that UNC has developed as part of their budgeting and advocacy efforts. So I think I'll leave it to Lakshman to flesh out the details. But we're lucky to have that case study today.
And I think that's a great transition. So thank you, Darcy. We have 2 case studies we'll be hearing from today. So hopefully, Maggie, by the end of this, we have a bit more to your question here. So thank you to our first 2 speakers. I'm going to now transition to our first case study from Terrorism Nepal. Laxman Chetri is the Asia Regional Advisor for WASH for Terrorism. And as Darcy said, has been doing extensive work on not just WASH and healthcare facilities broadly technically, but also looking at the costing, the budgeting, the financing of this issue. So Laxman, I'm going to pass to you, and I'll go ahead and move your slides forward.
Thank you, Darcy and Lindsay. First of all, my greetings to all present here. I believe I'm audible. This is our detailed costing exercise for WASH in healthcare facilities. We carried out in 8 healthcare facilities of, it's called Thakur Baba Municipality, that is located in the Bardia district of Nepal. And regarding myself, I work for Terrorism, which is a Swiss child rights-based organization. We are also a member of the Swiss Water and Sanitation Consortium, through which this project was implemented. And WASH in healthcare facility is one of the important components of the consortium project. Yeah, thank you. This for the second slide. Yeah, here we are talking about regarding the context under which this costing exercise was carried out. Actually, we conducted this costing exercise as part of our work to develop a model policy for advocacy. Actually, it was advocacy for operation maintenance, but later it was linked to budgeting, that will come later. Operation maintenance of WASH facilities in healthcare facility, working in the 8 healthcare facilities of the Thakur Baba municipality for advancing WASH in healthcare facilities by enhancing WASH coverage and quality of WASH services. But in addition to contributing to the development of this operation maintenance policy for the Thakur Baba municipality, the results from this costing exercise was also found to be useful in the Nepal roadmap for WASH in healthcare facility that was being developed by the Ministry of Health and Population of Nepal. Yeah, next slide, please. Yeah. Regarding the services provided by the costed 8 healthcare facilities, all 8 healthcare facilities offer outpatient department services, and half of these facilities are also equipped to provide laboratory and maternity services, including delivery. These are the 8 out of the 10 primary healthcare facilities located in the municipality, which serves about approximately 58,000 people. The remaining 2 facilities were excluded from the costing analysis because one lacked its own building infrastructure, and the other one was being upgraded, undergoing construction for upgrading to a hospital. Next slide. And the district of Bardia is located in the plains area of Nepal that borders India. Now, regarding the methodology, under methodology, we utilize the spreadsheet of it's called Costing of Environmental Health Services, developed by the UNC Water Institute team, which can be accessed at washinhealthcarefacility.org website. We adapted the tool to suit our requirements, and we also included provision for collecting data on output and outcomes indicators, because we had to monitor the status of WASH while implementing the developed operation maintenance policy, for which the costing was done initially. The output indicators integrated into the costing spreadsheets primarily focus on coverage and functionality of the WASH services. The outcome indicator is related to the use of WASH facilities, and this is to be collected separately. This is not yet linked with the costing set. Regarding data collection, we estimated the infrastructure costs for components lacking available cost data. Our engineer, who was experienced in constructing vast infrastructures, conducted these estimations. For other information that had not been recorded previously, such as breakdown frequency and repair cost, we conducted interviews with relevant staff members of the healthcare facilities. We have also developed now a tool for systematically maintaining such records at the healthcare facilities. And past costs were converted to present cost using the formula shown on net present value derivation. And we also refers to the IRC's guideline to understand about life cycle costing. Yes, next slide, please. Now, regarding the components, under costing components, it is in line with what Darcy had shown. Our analysis included capital and operation maintenance cost. Under capital cost, we also covered software costs. And for both capital and operation maintenance cost, we expressed existing costs and cost for additional investment required to improve coverage and functionality of WAS facilities or services. We also expressed the capital cost as annual capital cost starting from 2023 using an 8% annual discount rate over the lifespan of the WAS facility using the formula shown in green here. Yeah, we can move to the next slide. Yeah, our costing results. Here we are showing our costing results in terms of annual cost. Now, both the capital and operation maintenance costs are broken down to current, that is existing cost, and additional costs needed for upgrading coverage and functionality of WAS facilities and services, as mentioned earlier. The total cost, if you say what was the total cost for the 8 healthcare facility in 2023, it was calculated to be US dollar nearly 54,000. We can also see here that the fraction of the annual operation maintenance cost is bigger than the initial investment or the capital cost. We can move to the next one now. So now the immediate implications of our costing exercise. So carried out alongside the development of the operation maintenance policy for its advocacy, the costing exercise with the associated assessment of coverage and functionality of WAS facilities, it provided the basis for the policy, operation maintenance policy, for which it was intended. Now the policy, Thakur Baba Municipality Operation Maintenance Policy has been approved. And they have also, it also provided a basis for creating a recovery fund. They have a recovery fund for operation maintenance of WAS in healthcare facility. The municipality has created now an operation maintenance recovery fund for WAS in healthcare facility, totally approximately about 4,000 at the municipality level. And they have additional 150 allocated to each of the healthcare facility. So this is something new because there is a dedicated budget for operation maintenance. Now we can go to the next one, next slide. Yeah, national level impact and reference. And at the national level, our costing study was one of the 3 references for cost data in the Nepal roadmap for WAS in healthcare facility. So this can be because when they were doing the roadmap, they needed the basis for cost. So this can be taken as the demonstration of the impact of localized data-driven approaches on national level policy making. That's how we have been putting. Now the last slide. Next one is my last slide. Finally, because we are committed to continuing our work with the municipality in implementing the operation maintenance policy, but we will be, we have planned to introduce this costing exercise in a new way in our other programs in the region, particularly in Bangladesh and Nepal, because we want to use this for evidence-based planning, budgeting, and fundraising at a small level, because we'll be working at the district level, perhaps in Bangladesh. Sub-district level, and there is the provision for collecting the resources from the community also. We will be looking into that also, how a model for that can be developed. because we have recently, this is part of our Swiss consortium project that we have started recently. So there are opportunities for exploring a lot of things there. So we will be basing that on cost also. So finally, last. Yeah, thank you. If there's any questions, I'll be happy to take. But I must also mention that we have also made a poster presentation at the, Darcy had said there's a link of the poster made at the UNC event. I can provide that link later. And I must mention that Darcy was also with us throughout this process, along with colleagues from the Swiss Water and Sanitation Consortium, under which this project was implemented. Thank you.
Thank you
Over to
so
you,
much,
Lindsay.
Laxman. As always, such a robust presentation, and we appreciate you coming in the evening in Nepal. It's quite late for you. But I think that's so interesting to see how you've managed to look at the policy landscape and understand opportunities that you can utilize and leverage, particularly looking at developing an operations and maintenance policy and seeing where you can leverage new funding as well as existing. So thank you so much to Laxman. I now want to turn it over to our colleagues from Tajikistan. We have Omar Arkzai here, from the Chief of WASH from UNICEF Tajikistan, who has an exciting conversation around costing and budgeting, and in particular, a brand new investment case, a national investment case on WASH and healthcare facilities that they helped to develop with the government. So Amar, I hand over to you.
Thank you very much, Lindsay. Good morning, good evening, good afternoon to everyone in different parts of the world who is attending. I'll be mainly talking about the approach of what we did, and giving you a little bit of background rather than the details of the case, because there's a link already shared in the agenda for the detailed case, and you can have a look at that. We can briefly talk about the details as well. Can we move to the next slide, please? So to give you a quick background, UNICEF in Tajikistan has an intermittent history of working on WASH, but recently the program on WASH was initiated in 2019, and then a full-fledged program was established in 2023, only 1 year ago. At that time, when UNICEF was positioning itself, we also understood that the big picture of the WASH landscape in the country was unclear. At that point, many partners were investing in healthcare facilities, specifically in WASH and other areas, but they were working in silos, mostly coordinating with the ministries, but not among the partners. Roles of the ministries and key government agencies were mostly overlapping. There was lack of a single leadership. Multiple ministries were pretty much doing the same job and had split different parts of water, sanitation, and hygiene, and were not really coordinating with each other. And then overall, the sectoral progress was really unclear. The key priorities were unclear. So there was no collective vision on how to really move forward and how can we bring our efforts together to achieve certain goals and a particular vision. Next, please. So at that time, for UNICEF to really understand the issues and to really take strategic steps, we initiated working on a joint sector review, which was basically a sector-wide review of understanding the picture, looking at various components of it, starting with financing in the sector. And this was also, the information was also collected from other studies that was done, and also primary collection of data was also done at the same time. And based on an expenditure and budget analysis, we understood that the WASH sector was overall getting around 0.67% of the annual GDP, whereas the requirement was around 213 million annual until 2030, which also shows a huge gap. Specifically in WASH in healthcare facilities, this was comparatively better. It was around 3% of the annual GDP, but less than even 20% was allocated to WASH, and pretty much a very small amount basically for any recurrent cost at that time. There were no specific budget lines, no clarity on how this could be really, followed up, and no clear transparency as well. We also were able to look into institutional arrangements and capacities, which were quite limited. And as I mentioned, there was a lot of overlapping between key institutions as well, key ministries. The policy and regulatory environment was outdated. There was a national water strategy, which was a policy document. It was a draft document, never really approved. So there was no big strategic framework available in the country at that time. Country systems overall were limited and not really that strong. Overall, the planning, monitoring, and implementation capacities were limited. If we talk about WASH and in specifically on WASH and healthcare facilities. And then this initiative also helped us identify some strategic entry points for UNICEF to step into. And based on that, obviously there were a number of areas looking at the strategic entry points and strategic initiatives across the sector for all partners, but then specifically for UNICEF to position itself as well. And we started with updating the national WASH standards in healthcare facilities. So this country is also coming from a Soviet background. Since then, since its independence, the country has been dependent on the Soviet standards, which were pretty much outdated because the funding, the budget availability was comparatively very limited, and the costs were very high. And most of the infrastructure was, dysfunctional. It was outdated. And it required a lot of investment as well. So operations and maintenance was a huge issue. At the same time, when we did this, we also agreed with the Ministry of Health that there are some missing pieces of the puzzle which needs to be worked on by the ministry side. So we will focus on one piece of the puzzle while they have to work on the remaining. And that was basically to do a compliance survey of all the facilities. So obviously, we could only pick a sample. Whereas there was a system in place by the ministry to collect that sort of information in terms of compliance of the new standards. For example, if there are 3,000 facilities, how many out of those are really complying with the updated standards? And then what would it cost to really comply with the new updated standards? And this particular, then we obviously supported the development and endorsement of the WASH in healthcare facilities investment case. This investment case highlighted that there's a investment needed around 361 million US dollar until 2030. Out of this, around 136 million were OPEX, and then around between 180 to 224 was recurrent cost. And it was also highlighting that the biggest share of investment is needed at the primary healthcare level, which was around 68%. And then at the secondary level, it was 13%, and the tertiary level was around 19%. The urban-rural divide was also quite huge. So the investment required mostly was at the rural level, which is around 88%, and at the urban level, around 12%, because there was already better investment done at the urban level in the country. Next, please. So when we put together the investment case, the aim of this investment case, first of all, was to put together an advocacy tool and put together evidence that could highlight the needs, and it could also bring greater attention to the impacts of the lack of WASH facilities in the healthcare facilities in Tajikistan, so that we can highlight this to the government, specifically Ministry of Health, Ministry of Finance, key partners and donors. Secondly, it was also to ensure that we are able to quantify the impact in terms of financial terms. So initial estimates were put together, data was collected. I'll also come to the point on how we really collected that data. And it was also we also looked at the budgets in terms of currently available budget and what is being spent, what is the funding gap when it comes to WASH in healthcare facilities, to really quantify this, because generally we have been talking about this at various forums, but there were no really clear figures behind it. We understood and agreed with the ministries that this has to be really taken up to a next level where a detailed costing has to be done for each facility to come up with accurate costs. But this data provides a good amount of understanding already to initiate a case and to start allocating increased amount of funding specifically in this area. And PHCs, primary healthcare facilities, were at the top in terms of the need for that investment. This also helped us in terms of prioritization of needs. What is the most important, the most immediate investment? And I just mentioned that the primary healthcare was highlighted as the one that was the most important at that point. And we were able to highlight the cost of inaction in social terms related to public health, that if it doesn't really come in, this sort of funding, this sort of investment, what sort of impact is it going to lead to? And then finally, it also helped us really put together a costed roadmap in terms of identifying some key priorities, some key steps, and what would it really cost to take that forward. Next, please. So in terms of the approach and how we leverage that data, based on UNICEF's existing presence, which was in around 37 districts around the country, and there are around 66 in total, so half, pretty much 50% of it. We were already through financing from European Union, we were already implementing a project which was covering around 1,500 primary healthcare facilities and around 42 secondary healthcare facilities, whereas previously we had covered some between 18 to 20 secondary facilities as well. So we had a data of 60 secondary healthcare facilities and around 1,500 PHCs. UNICEF was also the co-convener of the WASH and Healthcare Facilities Coordination Platform. So we also had access to partners in terms of collecting data and in terms of understanding what sort of investments are they doing. Is it really in line with a particular structure in terms of particular standards, or is it different, to really understand that, okay, how is the costing being done? And all that data was basically collected for this exercise to understand different aspects of it. We basically separated this costing exercise into 3 levels. It was at the limited level, basic level, and improved level. The improved level was complying with the updated standards, the basic level with the GMP, and the limited level was a very basic limit level of access, so very initial level of access. Because some PHCs, for example, did not have access at all. And then there was a construction department at the Ministry of Health, which also collects this sort of data on an annual basis. They use it for their own budgeting. So that sort of data was also accessible, which we collected. Obviously, it did not cover all the facilities in Tajikistan, but still provided us a good amount of information. Below here, you can see the number of primary, secondary, and tertiary facilities that are in the country. And we basically looked at samples of each. Next, please. Okay, this is also the last slide, and it's also leading to basically highlighting what sort of key opportunities and learnings were there, and what would be our next step to take that forward. So this has been recently put together, and we are expecting that we are going to now work with the government in terms of additional allocation, specifically on this. There are also plans to do a formal launch and dissemination for this investment case. But a very good example in 2023 that we have, we would like to share that with you, is there was a UN Water Conference planned in 2023, and that required basically commitments from the head of the states on WASH, on SDG 6 specifically. And UNICEF was also involved in proposing and drafting those commitments. And these commitments were actually backed by evidence from the JSR, the Joint Sector Review that we did. And ultimately, 2 of the key commitments were taken by the presidential office in Tajikistan, and they were made. One was on increasing the financing, which was increased to doubling the financing, which was still not enough, but still better than what was being allocated before. So around 1.7% of the annual GDP was committed. And we also saw that, so not only a commitment, but we saw that the national state program on drinking water supply and sanitation was put together, and it highlighted that share of money, that share of funding into it. And secondly, there was a commitment on increased coverage, specifically on basic and safely managed services. Because the focus on safely managed services was a little weak in Tajikistan. There were not enough efforts there. But in the state program, this has been fully integrated, which has really paid off. And we have seen that there was a new national strategy put together, which is currently under approval. UNICEF has substantially contributed to it. And we are seeing that the results will come out of this. So this has all been supported by strong political will, which was used in a way that there was a particular opportunity, and we used that opportunity at the right time to be able to get to this level. So in terms of WASH and healthcare facilities, there's also another opportunity coming up, and it's not only for Tajikistan, but globally for all countries, is the Dushanbe water process, which is coming up. And this is also a global water conference happening in June this year. And UNICEF Tajikistan plans to present this case there and also gather some commitment from the government. This will also be basically linked to our work with the government on adoption of the protocol on water and health. So this is going to be joint. But we are also planning to work with the headquarters and our regional office to work with other UNICEF offices and other partners to see if this particular opportunity could be used to gather commitments globally by different countries and then use it in the same manner, which could lead to increased financing and better coverage of WASH in healthcare facilities. Yeah, I will stop here, and I'm happy to answer any questions that you may have. Thank you. Back to you.
Thank you so much, Amar. And I think it's really interesting to see the challenges you've all found, and that primary healthcare is also a concern in Tajikistan, as it was in the study that Claire shared that was in the least developed countries. That seems to be a continuing theme here where there's the greatest need, though sometimes people look first at hospitals. And really exciting about the Dushanbe water process and the opportunity in this June. We'll definitely need to circle back around and see what other partners want to join you and also how we can follow along with that. So we have just a few minutes left. If my esteemed panelists want to turn on their videos just for one final moment. There's one quick question I want to quickly ask to Amar and then to Laxman. And if you guys can give me a 60-second response, no more, we'll keep it tight. Laxman, the question for you, which I know you're chatting about, is whether or not the costing exercises looked at beyond just the infrastructure, but included IPC. And then Amar, I'm going to have you quickly answer on this question from Uta about collaboration and communication. How do you maintain ongoing exchange of information with the government and with partners around this? So Laxman, quickly over to you.
Yes, I answered. Yeah, we have all the detailed WASF training because we had software component also, even IPC also for cleaning also, because actually, so I have shared the link of our poster presented at the UNC event. So there we have highlighted the lot of cost was on operation maintenance cost was on cleaning also, cleaning.
Thank you, Laxman. And I think this goes to the point of what the scope is of costing really depends. And I think being really explicit with the government and partners what you cost. I think there was a question to also Amar whether or not you costed waste management as part of it. But over to you, Amar, for questions. Maybe you can also touch on waste management briefly. Thanks.
Thank you. Thank you very much, Lindsay. So responding to this waste management question, yes, it was basically water sanitation, hygiene, environmental cleaning, health waste management, and electricity. So it was completely as per the framework that is available. It included everything. On the collaboration and communication, I think the most important part is to really set a vision and then to see it together as a sector. And I think that's something that we have been trying to do in Tajikistan. And this particular coordination platform that I mentioned was key. Now, in many countries, such coordination platforms already exist, and they're quite useful. In Tajikistan, it did not exist. There were other coordination platforms for larger water sanitation and hygiene, but not specifically on wash and healthcare facilities. And when you go to health coordination platforms, the issue of water sanitation and hygiene pretty much it's lost there. So you are unable to really, emphasize on it. So I think that has really paid us off in terms of bringing partners together, in terms of really setting key priorities and then moving accordingly. So yeah, so I would say that collaboration is definitely key, but the right coordination platform and the right leadership is really needed. Thank you.
Thank you, Amar, and really just fantastic presentations today. It was fantastic to hear both more of a on-the-ground perspective in a micro scenario with 8 healthcare facilities, what the costing looks like as a project perspective. I hope that's useful for many of you who are working on the ground. And then a more high-level conversation from Tajikistan, if you are working with government, how you carry this forward. So really great juxtaposition here. Thank you to all our presenters, to Claire and Darcy for really setting the stage. I think I learned quite a bit in the first half hour this morning about how we talk about costing, budgeting, financing, and funding. So that is going to be all for today. The slides will be made available. The recording will be made available. There are already publications on these great case studies, as you saw in the chat. And please look forward for our next technical webinar, and we'll continue this conversation around who is paying for what. I think that might be the next discussion. So thank you all. Enjoy the rest of your day, and we'll close out here.
Thank you very much.